Well, good morning, ladies and gentlemen. As Keith said, he'd been LE'd. I've also been LE'd too. As you're probably aware from the programme, it says Jackie Fletcher. Well, I was told or asked a week ago that Jackie Fletcher wasn't coming, and I got asked whether I'd step in and give a talk on her behalf. So I couldn't say no. I came here last year and spoke about vascular assessment. So she said, I don't mind what you talk about, but can you cover a little bit on current constraints? So, and really, have we got time to care? Well, hopefully we get to the end of the presentation, and yes, we do have time to care. I'm not going to believe in any way that we don't. But it was really about having a look at the current constraints. So I sat and had a quick think about what really I wanted to talk about. So it was looking really at the sort of current arena. I work in the NHS. I'm sure a lot of you do. And it was really to look at the sort of constraints on healthcare. There's lots of problems, there's lots of changes. We do have to embrace change, but we also have to innovate as well. So I wanted to have a look at that, the sort of environment of care and the problems that are facing us. And also it's really relevant to the area of lower limb management. And also is how can we continue to progress in practice. And also there's been some new research this year with lower limb ulceration that I wanted to talk to you about. So I hopefully have covered what Ellie wanted me to cover, and also as well to present some information to you that I wanted to talk about. I've been in nursing for many years, and I'm quite proud to be a nurse, and I know from seeing a lot of you yesterday, you are as well. And we all have a professional registration, whether we're nurses or allied healthcare professionals or medics. We all have a governing body, and we all have a fundamental requirement to care, and therefore have a PIN number. And in law, we have an accountability. And for us as nurses, from 2015, we have a code of practice, and that sets the professional standards that we must uphold in practice. So we must prioritize people, preserve safety, practice effectively, and at all times promote professionalism and trust. So while changes go on, and we'll look at those changes in a moment, we have a responsibility for ourselves and also for our patients to raise any concerns. And with the code and with revalidation, we have also a responsibility to reflect on our practice and also the code. So that just sort of sets the scene. So the NHS, we know, is changing. It's actually the 70th year, so it's a celebratory year. But there is a lot of change taking place. And just looking through at some of the headlines, I've got a picture up there with some sort of third world A&E, our NHS is dying. It's a very sort of negative picture, and it's really easy to paint a sort of very negative view. It's certainly not my intention. I'm very proud of the work that, that we do as a profession and for the patients that we serve. And I think the staff work with dedication and skill. And I think sometimes it's not very helpful for patients to see these sorts of headlines when they're accessing our health service. So there are a lot of headlines. It's a very sort of uncertain future. And I think the public are very passionate about the NHS. But there are now multiple challenges present in practice. So headlines such as the perfect storm is brewing, there's evidence that the NHS is buckling under the strain, present the idea that there are sort of serious problems. And I'm sure a lot of you have heard of the mid-staffs inquiry, the Francis inquiry, where care and the service provision fell below the required standard. And what we're seeing really is that demand and activity continue to rise, perhaps outstripping supply, and there are tremendous financial constraints, operational pressures, and workforce challenges, and also an increasing workload, and we'll look at that in a moment. So there are many things going on that make it harder and harder to provide the services at the standard that we want to, but we have a professional accountability to maintain those. So why are we seeing this picture? Well, we're really seeing an increasing aging, frail population. More people are living longer with multiple comorbidities. And also as well, people are having difficulty accessing healthcare, accessing A&E, GPs practices, mental health services. It seems to be harder for people. And also as well, patients, when you talk to them, I think their expectations are increasing. They have more knowledge, they have more access to knowledge with technology, they have more or greater expectations from us. What we can't do is go backwards. We can't really sort of view things with rose-tinted spectacles. We can't sort of think, oh, it was good in the past. We have to function and work and provide care in the situation that we're in. So we really do have to embrace change, as Keith was talking about, and innovation, and we can be part of that, as opposed to sort of a top-down approach and just letting everything happen. We can innovate and we can change small changes at sort of a local level, and we can prioritize, be realistic, and we can move forward for patients as opposed to letting it all become very negative. And what I didn't want to do this morning was be incredibly negative about the situation. I think we're here to be inspired, to go back and provide the best that we can and to move forward. Wanted to have a little look on staffing. Obviously, that's a big concern for a lot of us. And reading through this, a significant and growing number of nursing vacancies despite more training places. It's the same very much in the medical profession, although they're opening that up. And in the community, a lot of district nursing posts have disappeared as well. So there's high sort of staff turnover and recruitment challenges. And staff, when you talk to them, are quite often demoralized, and I think coming to conferences is quite inspiring for people. And often we feel that there's insufficient time, really, to complete or to give care, and that we feel there's great pressure on us from a workload perspective. I think staff often feel that they're sort of continuously firefighting. There's tremendous pressures. And often as well, the skill mix within practice is changing, and we'll talk about that in a wee while. We certainly know that lower nursing numbers are associated perhaps with poorer patient outcomes, what we call missed care and significant harm, and that's something that we're desperately wanting to avoid. We have a responsibility to practice safely. So the NHS needs a workforce of correct proportions with the right skill mix to guarantee the delivery of consistent and high quality care in practice. So we have to maintain that due to the rising challenges. So we're under immense pressure to maintain the safety and quality of services really at the same or less cost than previously. We've got what we call winter pressures. We seem to have pressures all year round in the NHS, but we talk about winter pressures. It leads to increased bed occupation, which means that we can't do elective surgery, we can't get people in. That increases waiting lists. We have great difficulties in discharging patients. We have bed blocking. We have delays in getting patients, once they're in the hospital, actually getting them back out. It just backs up the problem. We have an increasing amount of patients coming to A&E because they can't access services in primary care. And there's a sense of lack of joined up working really between sort of health and social care. There are, and we'll come on to that, there are plans in place to try and address that. And quite often for us, we feel very pressured time-wise and that we have sort of not enough time to provide the care that we want to do. So that's becoming more of a challenge. So it's increasingly difficult to sustain the existing services. So we can't keep doing what we've always done because the demands on the service are just increasing. So some further considerations, and we were talking about safety, and there's very much, and I thought people are worrying about sort of complaints and litigation. So if we actually try and reduce the services and staffing at one end of the spectrum, we also then have to find money if there are increasing failings in safety and negligence to actually pay for litigation. So we're saving on one hand and then maybe spending out on another, and the costs of litigation continue to increase. So the situation really can't continue, and we need a good, sufficient, competent workforce, whatever that future workforce may look, and that may well be very different. And in order to do that, we need the right people in place, and we need strong leadership to create and manage these teams and take them forward. So really the situation can't continue. So what I wanted to look at now really were the sort of following measures, the measures that are in the background. Some of you may know about them, some of you may not, but what we can make change locally, but nationally there are plans in place to try and embrace change and move things. Otherwise, things may well collapse. So the policy solutions moving forward. I expect quite a few of you have heard of the 5-year forward view. It came out in 2014, so that's 4 years ago. It was readdressed or revisited last year, and that's really a plan to try and address this gap between funding and demand. So essentially what it's trying to do also is address the gap between health and well-being, care and quality, and funding and efficiency. So it's trying to align services between health and social care. So it involves different ways of joined up working, and that's probably something that you're hearing in clinical practice. Agencies, people working together, very much we've had hospital, we've had community, now trying to work in collaboration with social care. So essentially what we're trying to do is to help frail and older people stay healthy and independent in the community and keep them out of hospital and stop them revisiting hospital in a sort of cyclic sense. You may well have heard of things like STPs, Sustainability and Transformation Partnerships, STPs, really which is partnership working of care providers and commissioners. So it's more joined up working, hopefully for the benefit of patients and trying to keep patients out of hospital. And there's a move towards fully integrated care with much more freedom. And you may hear about accountable care systems, and that's something that's going to come in forward. So essentially it's integration of health and care services, so it's doing things differently in a more innovative way. And also as well, I think we'll hopefully see sort of hospital specialist teams. We're very much bound in hospital with the new ways of working and joining up together, that hopefully we can take some of the hospital expertise out into the community and we can break those barriers down and work together and lose this traditional referral between secondary care and primary care, which is often a very delayed process and quite stressful for patients to come to hospital. So I hope from change from my perspective that we can actually go out and start working with our community colleagues as opposed to sending everyone to secondary care for referral. From a nursing perspective, you may well have heard of leading change, adding value, which is a fairly recent framework. Again, this is about reducing variation, and we'll talk a little bit about variation, and trying to improve the outcomes for patients. And that's very much aligned to the 5-year forward view. So these policies are in the background to try and facilitate some change. And you've probably heard of the 6 C's, the 10 commitments, which is trying to refocus nursing to the changes that's taking place within clinical practice. So there are plans in the background to try and move things forward, as opposed to just letting everything collapse really around us. Looking at the environment of care, and I'm, I suppose, very hospital focused, although I do have a little bit of community focus as well, but my background is very much hospital sort of focused. So the environment of care is really important. So a very positive environment is really associated with a small volume of care left unperformed. And that workplace should really be, if we can work towards having a very positive environment where staff have a greater degree of autonomy and continuity of care, and positive relationships between staff really help that. And teamwork's really, really important because it leads to increased job satisfaction, and it also reduces the risk of burnout. And that's something that staff working continually under pressure is really important. So our workplace culture is really important, and we have a responsibility for that. The people that manage and lead teams have a responsibility, but also employers have a responsibility to try and improve the work-based culture and provide the support services so that we can function within that. And that's vital so that we can avoid burnout. Looking at the workforce, because without a workforce, we don't really have a service, and that's really the most important part. Probably what we're seeing, we were saying there's lots of vacancies, both on sort of nursing, medical, and allied healthcare professionals. So how do we provide that service? As we said, we can't look back. We can't take things back to how they were many, many years ago. So we're seeing additional challenges. We're also seeing traditional boundaries hopefully being challenged. We now have lots of other roles. We have nursing associates coming through who will have a PIN number, who will have NMC registration. We have assistant practitioners. We have advanced clinical practitioners or advanced nurse practitioners. We have physician associates. So for a lot of professions, allied professions, there are additional colleagues that we're working with, working in a different way, providing a different service. And I think it's confusing for patients. It's certainly something that we need to get our head around, but we do need to provide a service for patients. And I think these people will be part of that future. So we will see a very different landscape in the future with staffing. What we do need is enough people in clinical practice to provide, who are competent to provide the service that we want. What we can't do is really allow the people that are working to lose the passion to care for the people that we see in clinic, because that's just so important. So we have to develop in some way a resilience really to thrive, to cope in this modern NHS which is changing and under great demands. But we do really have to embrace change as we move forward. Things are not going to stay the same. We're only going to get the same results, and our demand is increasing hugely. So further considerations with constraints. We've looked, there are many constraints that face us in clinical practice. So as everything is changing, we need to really have much more of a working partnership with the patients that we have in clinical practice. We obviously have a responsibility, we have an accountability to provide care, but patients also as well have a responsibility. We talk about self-care, taking some responsibility for their care. And again, that's a form of innovation. Many years ago, we kind of did everything for the patients. Nowadays, we're trying to get people to self-care, take some care, responsibility for care, for their own health and well-being. We all, maybe as we move through life, suddenly realize that we're not invincible and that we can't just do everything we want to do and still feel well and able. But patients do have a responsibility for their own health and well-being. And I think we, as nurses and allied health professionals, need to promote that. One of the key difficulties really is that for a lot of people, their influence on their health is their money, their economic status, their physical and social status, where they live, and the environment in which they live. And some of those things we can't actually change strongly. So that affects people's health. But for a lot of people we see, they can take some responsibility for their own health. So looking around, reading around, also we've looked at the policies, what's in the background. There were some ideas which I thought were interesting. They came from sort of Scotland and Wales. And that was about the idea of introducing realism into healthcare. What can we do? What's realistic to achieve? We'd love to do absolutely everything, but we can't. We can no longer do everything. So we have to be realistic in what we can achieve. What are our expectations? And I think that's something that we need to look at. I'm also very passionate about asking patients of what their expectations are. And I think that's quite a good way of tailoring care specifically and looking at really what they want. So I think the concept of realism, for me, I think is very important in what we can actually achieve, and goals. And it's like setting goals with patients that we see around dressing selection, what sort of input do they want, and treatment plans is really key. Looking at Wales, I found some ideas about prudent healthcare, which again is, I think, follows on from the idea of realism. So we've got to engage our patients. We've also got to prioritise those most in need. We can't do everything. And I think we have to be doing that is really important and is needed. And again, delegating appropriately and safely to our allied colleagues that we'll be working with in the future. Essentially, we really want to cause no harm, but also as well what we want to do is reduce variation. What we need to be doing is providing evidence-based care so that we don't have variation and we're not wasting our time doing things we shouldn't do. I think the key message really is that we need to get it right first time. We need to follow standard evidence-based pathways, and we need to get it right from the start, and prevent, certainly with lower limb wounds, chronicity, suffering and pain. So hopefully you'll see by the end of today and certainly this talk that there are sort of changes in place where we can actually improve the management of patients. So we do have to really continue to support sort of local change and innovation, and I think we can all make a difference. Despite all of the changes, I think we can all make a difference in clinical practice on a daily basis. What I was going to move on to was looking at constraints very briefly within wound care, and then have a look at a possible change in practice, certainly with lower limb venous disease that's come about this year, and hopefully that's something that we'll see coming through into practice. We all know that lower limb ulceration causes considerable time and misery for patients, and a lot of money. The sort of $3 billion that's spent on chronic wounds, a good $2 billion is spent on leg ulceration. So a lot of money is spent on that, and that's public money, and we have a responsibility when we spend that money in clinical practice. And a lot of that cost is associated with nursing time, not the dressings. It's us and the cost. So if we do nothing, if we make no changes, if we continue what we're doing, and maybe from the evidence we haven't always been getting it right, the burden is going to increase. We've got this increasing aging population. And lower limb ulceration has a significant impact, as we're all well aware, on people's lives, the caregivers, and it's also a financial strain on the NHS. Most of you are probably aware there's a wound care sequin which came out sort of 2 years ago, which hopefully will bring some degree of standardization, improve outcomes for patients. And again, we're talking about this idea about reducing variation, but it's also a challenge to implement in clinical practice. So moving on to perhaps an area where I have a slight interest, really is lower limb ulceration and essentially venous disease, which is essentially, I suppose, where within the NHS I spend quite a lot of time managing. And I think traditionally we've seen compression really as the mainstay. We know it's the sort of gold standard treatment, but it's really the very conservative management of lower limb ulceration. And what we do know, it doesn't treat the underlying problem. So, and we also know that many commissioning groups consider varicose vein intervention as a sort of low priority, as a low value. And we don't see venous disease as a chronic disease. We see varicose veins very much as a sort of cosmetic problem, and it's only part of venous disease. So I think the current situation is very reactive and not proactive, really, in a way. A lot of us have heard or read the work by Julian Guest with the Burden of Wounds study, which was raised significant issues regarding lower limb management, that a lot of patients didn't really have a diagnosis. We know that leg ulcer isn't a diagnosis, and a lot of patients were in compression but didn't have ABPIs. And also as well that too many patients received what we know as reduced or suboptimal compression, which is not necessarily therapeutic if they've got no arterial disease. So therefore, by persisting with that, are we providing some degree of clinical harm? Are we doing the best for our patients? Last year, NHS England, as part of the Right Care initiative, brought out Betty's story. I remember standing here last year with a slide about Betty's story, which looked at the variation in care. It was trying to reduce variation. It was a fictitious story about a lady who develops a traumatic leg ulcer but has underlying venous disease, and how she's kind of mismanaged or poorly managed over 2 years. I'm sure some of you have read that. It really was a view to try and sort of standardize care provision and to reduce variation, but also as well that we have, you know, responsibility to empower patients and carers, and hopefully some patients have read that and thought, this is me, you know, how can I improve the care that I get? What it hopefully has done is, if it's empowered patients, is to get them talking about what they want, and I think we do have to empower our patients. And I think talking again, I mentioned it earlier, about talking about patients' ideas, their concerns and their expectations, is a really powerful way of tailoring care. What do they want? What are they expecting? And often that's very different from our expectations in practice. And I think something from experience, I find talking about expectations opens a very interesting discussion with patients. They're quite often not what we would believe them to be. And that's a very simple but important thing to do in clinical practice. One thing I know, there's a talk later on today about Legs Matter, but again, we're passionate about the work that we do. We're here at a Leg Club meeting. The Legs Matter campaign, which I think there's a talk on later today, again, it's about raising public awareness. If we want change, we can produce care pathways, you know, but at the end of the day, we need to get the public on board. We need to raise public awareness about this problem, which has been, well, it's been there for years. It's never kind of gone away, and people don't want to talk about it. But also as well, hopefully the campaign will heighten political recognition and allow patients to access to sort of high quality evidence-based care. What we can't continue to do is continue to provide the way care is at the moment. There are improvements that take place in the future. And venous leg ulceration, essentially, at the end of the day, is a marker of morbidity, so it is quite important. So I wanted to talk to you in the last sort of few minutes, really, of this presentation about some research that has been going on for several years, but the results came out in April of this year. And I think if we're looking at providing the best care that we can, then I think research needs to inform practice. As we've said, compression has been the mainstay. We're not suggesting in any way that we should move away from compression, but this adds to the body of evidence to consider for patients a change in practice. And it's something, when I spoke here last year, that I mentioned was taking place. But we now have the results, so I'd like to bring those to you. Why is research important? When you say talk to a lot of people, they kind of think, oh, research, oh dear. But when we look at the evidence and what we've discussed, we really can't continue necessarily to do what we're doing. The landscape is changing, the skill mix is changing, the demand is changing. So as I said, we need to kind of get it right first time. we've got this aging population, we're going to see more and more people with lower limb ulceration. So our practice has to be cost effective, it needs to be safe, and it needs to be evidence based. And as we were talking about, we've got less people, we've got less skilled practitioners. And we know that recurrence of venous leg ulceration is high, concordance with hosiery is perhaps poor, but certainly through the work of the leg clubs, that reiterates the importance of that for patients. So maybe evidence offers us an opportunity to improve practice. This is, I suppose, an important or seminal study from about 2002, which one of my consultant colleagues I worked with was involved. So that's 16 years ago. So it's quite a long time ago. NICE, when they published their guidance on varicose veins back in 2013, they actually spoke about leg ulceration, and they suggested some referral to vascular, and they also suggested some possibility of intervention. But the ESCHAR study from 2002 was a randomized control trial, and it looked at using patients with compression and compression with surgery to treat their underlying venous disease. And what that showed was that if you surgically corrected, so they had traditional surgery, combined with compression, it reduced their 12-month ulcer recurrence. So it reduced the risk of recurrence. We had no idea, and it was never set up to see whether it had any effect on ulcer healing. But we knew that by treating the underlying condition, we reduced the risk of recurrence. And that fact was highlighted in the NICE guidance. Has it made a lot of change in practice? I think that's open to debate. The EVRA study. So the evidence basis we have further evidence. The evidence base has changed. So EVRA stands for Early Venous Ablation Ulcer Study. And this was a study that was started in about 2012, 2013. It's an NHS study. It was based up at Imperial College London, and it was a study that in Plymouth that we were part of, and we recruited patients for the study. And it was a study that I was quite passionate to be involved in because I believe that it potentially could give us the evidence to change practice. We can't stand in front of people and say, this is what I believe, without the evidence. Well, we do have some evidence now. I know we can always question evidence, but I believe this to be a reasonably good study. So what were they setting out to do? What they were setting out to do was to see whether treatment of the underlying venous disease can improve ulcer healing in addition to compression therapy. So often studies are quite complex. This was a fairly straightforward study, and it was published in the New England Journal of Medicine earlier this year, and that's the actual title slide. So it was a very simple design. It had two arms. Both arms received compression, but one arm received treatment of their underlying venous disease within 2 weeks of referral. And the other group received their treatment once they'd healed. And the sample size was about 450 patients, so it was a good amount of patients. And they were divided into two groups, and they were randomized. It was, we had no involvement in that, to either group, and they were happy to be in either group, because either way they got what was the gold standard treatment, and the other group got treatment. The other group were the deferred group, so they got treatment but at a slightly later date, very much in perhaps the way that care used to be previously. So we wanted to see if we treated them early, did it make any difference to wound healing? The inclusion-exclusion criteria were quite straightforward. Most of the people we saw had no significant arterial disease. They had to have had an ulcer for between 6 weeks and 6 months. So we weren't treating people greater than that because of chronicity. And essentially, we were looking at superficial venous disease and not deep venous disease. So it was very straightforward from that perspective. And everyone got therapeutic compression. Everyone got local wound care as per the policy, and then compression hosiery usually once they're healed in these two sort of simple arms. And essentially, what we wanted to know, the most important thing we wanted to know was the time to ulcer healing. So did it speed up ulcer healing? We also looked at sort of cost effectiveness, ulcer healing rate, and also as well ulcer-free time, as well as sort of quality of life. Did it improve their quality of life? So with the modern endovenous treatments, which I'm not going to go into because I don't have time to do so, but that may well be coming this morning, the modern treatments have really widened access. A lot of the patients that we see with lower limb ulceration, they're not fit, they're not suitable for surgery. But these modern walk-in, walk-out treatments that have no requirement for sutures, general anesthetics on the whole, and they don't require convalescence. So they're essentially walk in, walk out, and they can return back to their daily activities. So these patients quite often can receive these treatments very agreeably. So patients were randomized to the two groups, and they were seen in hospital at 6 weeks, 6 months, and 12 months. The rest of the care was provided by their community practitioners on the whole, but they had assessment obviously by us. And the early group received their treatment quite early on, and the deferred group once healed. But everyone received compression and standard care that we have the evidence base to provide. Interestingly, between 2013 and 2016, nationally, 6,500 patients were screened for the study, but only 450 consented. A lot of the patients had ulceration for greater than 6 months, so they'd taken well over 6 months to actually get referred into secondary care. And I think that's failings at lots of levels. I'm not going to point the finger and blame it, but there was a lot of patients referred and a lot of patients unsuitable, essentially because they had ulceration for a significant length of time. And I think that's just important too. And the groups were fairly evenly put together. So the results, we've looked at what the study involved. Essentially, healing in the early intervention arm was significantly reduced when compared with the deferred arm. And the median ulcer healing rate was reduced from 82 days to 56 days. And the ulcer healing rate at 24 weeks was 85.6% and 76.3% in the deferred group. So both groups did well, but there was clearly a significant difference for those that received treatment earlier on. And that's statistically significant for those that received early treatment. There's a graph there showing time in healing on the bottom trajectory, and then a percentage cumulative healing rate on the vertical axis. And again, the top, the green line is the early cohort, which shows, again, improvement in healing time and healing rate. So early treatment of their underlying venous disease, what we call endovenous ablation, in addition to compression therapy, which has been standard therapy, was associated with a shorter time to healing and greater ulcer-free time. So this is really the first. There's been lots of cohort studies. I've been involved in cohort studies. This really was the first large randomized control trial, so high sort of level 1 evidence that early venous ablation, early treatment of the underlying venous disease accelerates ulcer healing for this cohort of patients. And it's also associated with greater ulcer-free time, and also as well they looked at cost effectiveness, and they believed it to be cost effective to do so, because it's another cost referral into secondary care treatment. But in the original guidelines from NICE, it was suggesting that that was what we're doing for patients. So the implications for practice, that we should really have rapid assessment and treatment of their underlying venous disease for patients with venous leg ulcers. That has not been standard care. We have not had the evidence until now. So a lot of the pathways that have been created perhaps need to be reconsidered, revisited, to consider this evidence, because otherwise, are we providing the best care for patients if we know that we can do something to heal ulceration quicker? And also as well, I think we need to empower patients. Patients need to know about this. We were talking about commissioners seeing veins treatment as of low value. Maybe we need to empower the patients to actually be asking for this. We need to make you guys aware, people working in clinical practice, and also educate our healthcare professionals and the commissioners that we work with. I think that's really important that everyone knows. I don't know what's wrong. If you want something to be known, put it in the Daily Mail. I have patients coming to me in clinic and going, oh, I've seen this in the Daily Mail, can I have this dressing, that dressing, this treatment? I will say to them, look, it's great because you've taken an interest in your healthcare. You know, you've thought about it, you want this. It may not be appropriate, but, you know, there's usually, it's a piece of evidence on about 3 or 4 people, and there's no real evidence to support it, but they want it. So they read it in the Daily Mail, but one thing that's been in the news, and patients sort of come into clinic going, oh, you're not going to treat people anymore on the NHS with venous disease or varicose veins as they know it. So there was an article in there talking about the EVRA study and the need to treat underlying. So, you know, why would the NHS be wrong to stop treating people for varicose veins? And again, we have some evidence to do so. And what we have to remember is a lot of these patients may not have visible varicose veins, but they have signs, clinical signs of venous disease as such. And I think that's something that people need to be very mindful of. So hopefully if it's got into the Daily Mail, patients may be seeing, and I think we do need to empower the patients that we work with. Royal Society of Medicine in 2017 called for referral to vascular and assessment and intervention plus therapeutic compression. And I think we really do need to be looking at sort of future care pathways and services. We were talking about integration of services sort of between primary and secondary care, and hopefully with breaking down those barriers, then we can work more closely with our community colleagues. And I'd certainly like to take some of the work that I do out into the community. It won't be appropriate to refer everyone, it wouldn't be appropriate to treat everyone, and I'm sure if we talk about patients with what their expectations and what we'd like them to do for us, I'm sure that they wouldn't necessarily all want treatment, but I think it's important that patients have the opportunity to make that choice. So the implications for practice, compression therapy, and it's available in a variety of ways, really remains key, but we do need to have very clear, very standardized, very evidence-based clinical care pathways, and not just localized to different areas. I think it needs to be very much on a sort of national basis that makes people aware, and I think we do need to have full engagement of everyone that's involved. Vascular services need to be able to cope or to deal with the way forward. And I think patients should always continue to have a clear diagnosis of their ulceration in primary care and compression. None of this should change or delay getting treatment, getting it right, and getting it right first time in clinical practice. So just to draw, I appreciate time is moving on, but just to try and draw things together, we've obviously initially looked, the care situation in the NHS is becoming more challenging every year. We've got staffing challenges, we've got increasing pressure on those services, we've got new ways of working, we've got policies in the background to try and integrate, try and break down barriers. So it is a very challenging field to be working in. But as we said, we can change, we can innovate, and hopefully I think we need to be embracing change. We just can't keep doing what we've always done. So we've looked at some evidence which we know that increases healing rates, and also with good reduces sort of nursing interventions. The results from the EVRA study show that there is great benefit with ulcer healing with treating the underlying venous incompetence. So I think we do have to call for evidence-based change, and we also as well have to challenge apathy, people that don't want to change services, and I think we have to empower patients. So with all the pressures that are around, I was obviously thinking about this, I thought you see the 6 C's and the, in vascular we have the different mnemonics. I came up with the 3 R's. I think we need to remain very resilient in practice. We need to be reactive, and also as well we need to be realistic. And I think from sort of taking this presentation on at very short notice, I think we do need to be realistic about what we can achieve. And I think, you know, as nurses, as allied healthcare professionals, I think we need to continue to care, and I think we need to continue to embrace change really with resilience and passion. Thank you.